Awesome. Thanks everyone for joining us today. This is our quarterly webinar with the Mountain West Cancer Collaborative here at Huntsman Cancer Institute. And today we'll be talking about engaging with American Indian community and tribal communities, research best practices, and practical strategies. Next slide. So just an overview of our conversation today. I'm going to go over some basic information about Huntsman, the Office of Community Engagement, and the American Indian Program here at Huntsman Cancer Institute. And then I will share time with Dr. Smith, and she'll go over setting the stage for cancer burdens in American Indian communities, and then turn the time over to Hillary and Jeremy from the Utah Department of Health and Human Services, Office of American Indian Alaska Native Health and Family Services, to talk about best practices and engaging tribal communities. And then as we close out our speaker session, we're going to highlight a lot of great work being done in the area that we serve with Dr. Woodall, Dr. Adams, and Alma McCormick, and then wrap up with some question and answers. Next. So at Huntsman Cancer Institute, we are a comprehensive cancer center, but specifically an NCI designated comprehensive cancer center. And that means that we, as a comprehensive cancer center, provide a wider spectrum of care for patients in the communities that we serve. If you'll notice the map here on the side of the slide, you'll notice that a lot of the NCI designated comprehensive cancer centers are concentrated either on the East Coast or on the West Coast, right? And historically, this has been the case for a lot of what the comprehensive cancer center catchment areas have looked like. Now, if you look towards where we are in the Mountain West, there are hardly any NCI designated comprehensive cancer centers. So Huntsman Cancer Institute, which started in the late 90s, early 2000s, was servicing most of the state of Utah. But we had been accepting patients from the surrounding Mountain West area and engaging with communities in the same area for many years. In 2021, we formalized our commitment to the five-state Mountain West region to include Idaho, Montana, Nevada, Utah, and Wyoming. Serving this area, which is just to note, 17% of the continuous landmass, which is a lot of area that we have committed to working with, building relationships, and maintaining the relationships we do have. This is about 10.3 million people, 43 plus tribes and nations, and just over, we oversee about 3,500 annual cancer cases. And so you can imagine the work that we do and the work we want to center today. Next slide. So a lot of this work that we're doing through the Mountain West Cancer Collaborative is housed in the Office of Community Outreach and Engagement here at Huntsman Cancer Institute. And our mission is to collaborate with community partners, patients, patient advocacy, and clinicians, researchers, students to address unique cancer-related challenges in the Mountain West, a lot of our rural and frontier communities. Again, servicing the five-state Mountain West region and focusing on building partnerships with community-based organizations, enhancing community awareness and education, improving access to care, and driving long-term data-driven solutions. And this is a picture of our team, all of us here. Next slide. So in the work that we do and partnering with the people we work with, the organizations we connect with, and the tribes, our office connects research, care, and communities across the Mountain West. The picture you see here on the slide is from our recent Mountain West Cancer Summit, where we invited a spectrum of people from the Mountain West to come to Huntsman and talk through strategies and working with patients, addressing those cancer barriers and identifying best practices. We center our work in listening first to our communities that we work with and building trust through consistent, persistent partnerships, and then supporting community-led approaches to prevention, education, and care. Next slide. So before we jump into our speaker session, I just wanted to share some information about the program I work in. So I'm an enrolled member of the Navajo Nation, originally from the Southwest part of the state in the Four Corners area, and I'm currently the program coordinator for the American Indian program here at Huntsman. Next slide. And so the American Indian program is predominantly an outreach and education program, which aims to meet the needs of American and Alaska Native and rural and frontier communities. We strive to listen and learn from cancer patients, caregivers, healthcare professionals to provide interculturally competent care. Our program was started by my supervisor, Phyllis Massey, who is Oto and Cherokee from Oklahoma. And it started in the early 2000s when there was a need for more tailored outreach to our tribal communities. The disparities within those communities were very high. Phyllis often shares with me at the time when she started the program, it was very rare to even utter the word cancer. And so a lot of the work we've been doing over the past 2 decades have been increasing education, talking about screenings, risk reduction, and clinical trials. Next slide. Um, And then at Huntsman Cancer Institute on the hospital side, within the Office of Patient Public Education, is hosted our team of patient navigators. And these are amazing individuals who work with Spanish-speaking population, adolescent young adults, and rural and frontier communities. This is Mariela Sanchez. She predominantly works with the American Indian, Alaska Native patients who come to Huntsman. And a little bit about patient navigation. The navigators serve as educators and advocates. They work closely with the patients, families, community resources to provide culturally responsive support. They document patient encounters and help patients navigate the complex healthcare system. As you can imagine, coming from either Montana, Nevada, Idaho, or Wyoming, there's a lot of need in understanding those patients and where they're coming from. And so Mariela does her best to connect them to resources, things like appointment scheduling, clinical trials education, conference calls with their care team, lodging support, prescription refills, and transportation coordination. Next slide. But in the American Indian program, we have a long history of listening to our communities to better serve them. This is a picture of our formal community advisory board, some great people who helped us with a project just before the pandemic. It was great to get to know them a little more in this capacity. These were community members who the program has been working with for a long time, but formalizing a community advisory board allowed us to get their input and feedback into the work that we're doing. And then also continuing on with the outreach in the communities, making sure that we're teaching cancer basics to increase awareness around screening, risk reduction, and also research and clinical trials. And then a part of that is connecting communities to research. So investigators or providers who are looking to learn a little bit more about best practices and working with American Indian communities, my supervisor Phyllis and I have done our best to connect them to communities that we work with, but also sharing with them the best practices and being a good relative in this approach. And then staying connected to communities. So that means attending as many community events as we possibly can throughout the year, which means I'm traveling nonstop, especially over the summer when it's powwow season. Next slide. And then turning around back here at Huntsman on site, the American Indian program has done its best to connect patients with spiritual care and comfort care. And so we have a relationship with the chaplain's office here at the hospital and making sure that they have prayer supplies for patients and a designated smudging area on our patient patio. But also, like I was mentioning with Mariella, coming on board as the patient navigator, working with our American Indian Alaska Native patients, the program has a long history of also doing some of that navigation lift and supporting patients, caregivers, and survivors. And then also the training component, making sure that the next generation of providers and researchers who are interested in working with rural, frontier, or tribal communities are doing it with best practices. Next slide. And then advocacy and action. So over the past 2 decades, my supervisor Phyllis has made sure that our relatives in the communities we work with are not forgotten, either on the national level, where she has been advocating for patients and their experiences with national organizations as AACR, or working directly with the White House Presidential Cancer Panel on making sure that tribal communities are not left out of that conversation, but then also bringing HCI's hospital leadership to our communities and making sure they're hearing directly from our tribal partners on what they go through and what it's like to serve their patients. Next slide. So this is just some contact information about the American Indian program, about Phyllis and I. I'm happy to share that later if you have any questions. Next. And then if you're interested to learn a little bit more about the Mountain West Cancer Collaborative, you can scan this QR code. It should link you to our newsletter that you can sign up for. So feel free to do that now if you would like. The Mountain West Cancer Collaborative is Huntsman's approach to connecting state organizations, community organizations, patients, and survivors from across the five-state area to come together to talk through solutions and share resources. A lot of peer learning, best practices, alignment around rural cancer priorities, and working groups to elevate local expertise. Um, Next slide. So some objectives for today. As we go throughout the webinar, we'll be highlighting the importance of American Indian engagement and cancer coalitions, sharing strategies and examples of successful collaborations, and identifying actionable steps to culturally respectful partnership building. Next. So I'd like to share the time with Dr. Smith, coming from the University of Montana. She will be talking about setting the stage for cancer burdens in American Indian communities. Dr. Smith.
Okay, and she is just joining as a panelist as she gets set. Just a quick question from the chat, Nathan. So Mackenzie Sly said the Benefice Letton Cancer Institute in Great Falls, Montana is the only dedicated cancer center place that she is aware of in Montana. How does a place become a comprehensive cancer care center?
Mackenzie, thanks for asking. So it's a process in which involves a lot of rigorous meetings with the National Cancer Institute and the National Institutes of Health. So being if anyone from the Office of Community Outreach and Engagement is on the call and would like to also fill in a little bit, feel free to jump in. But my understanding, Mackenzie, is that it involves a strict, rigorous understanding of not just clinical care, but research. So making sure you have the highest standards of scientific approaches and working with communities and population science. So there are different type of research that is being done here at Huntsman Cancer Institute. And so we are in connection with the University of Utah. And so a lot of what we do here is liaised with the University of Utah. But I know not all NCI designated comprehensive cancer centers are connected to a public or state institution. But that kind of gives you a little framework on what that looks like to become an NCI designated comprehensive cancer center.
Thank you, Nathan. Awesome. So we will jump in with Dr. Smith. Dr. Smith, I will share your PDF slides unless you would like to share your slides from your end.
You can go ahead and share those slides.
Okay. All right. Okay, go for it. You let me know when to move forward.
Excellent. Hamadakiapi. Okay. Nixugoax. Hello, my relatives. Today, my slide set is entitled It's in the Stories We Tell You. And part of what I do in the work that I have been involved in over the decades has been really trying to help contextualize the journey of our patient population, our tribal communities as they move through healthcare systems, as they engage with healthcare providers, researchers, and really be able to understand not only the complexities, but also the journey and the history within policy, within the lived experience, and how we arrive where we are at today, and how we can make changes to be better uh, responsive to the needs of our tribal communities. So in the slide that you see here, you'll see a number of different pictures of my own family. In that first picture, you'll see myself, my middle child, my daughter, and then my mother. This was at one of her very first cancer appointments. And in order to get that to that cancer appointment, that was quite a journey in and of itself. Moving through Indian Health Service, uh, trying to find proper purchased referred care referrals, navigating transportation, and then everything that culminates in that lived experience and the fear that our family had at that time, knowing that there was so much more to unpack than just that medical visit. And so I want to share with you a little bit of insight into that. Next slide, please. Part of that is understanding that while we have so much diversity across our tribes, myself, I am Lakota, Sichangu, as well as Blackfoot or Apatosipigani from Brockett, Alberta, and then from Rosebud Agency in South Dakota, where I was born. What I've learned is that not only are our uh, tribal communities so rich and unique in their diversity, in the different history, the language, the traditions, and belief systems, there's also some similarities across that landscape that are very helpful in understanding. So, being able to first acknowledge that we have that rich diversity amongst so many different tribal representations out there. We're also very interconnected, and relationship and kinship is absolutely integral to who we are and how we move through this world, through our values, our beliefs, protocols, our language. And our language is so very important. It's the lens we see the world, our connections to our land base, our stories that are our history that tell us exactly who we are, where we came from, and the direction we're moving forward. Our songs that are deeply intertwined with uh, our people, our relationships, how we see the world. And all of that culminates in this holistic understanding of our existence. And when we circle back to our Indigenous language, understanding and recognizing that as we move through different tribes, our language is the vessel for traditional knowledge. It's an ecological understanding. There is cultural and spiritual framework that surrounds our language. It's that holistic connection, identity. It's the way we see and interpret the world. It is so much more complex than what the English language allows us to convey or has the capacity to express. And so being able to understand that even with my own family, as they've moved through healthcare systems and through their cancer journeys, uh, they coming from uh, their indigenous language as their first language, how they're able to describe and express themselves within a clinical setting is oftentimes very difficult. Next slide, please. So I'm going to ask that you listen thoughtfully. The slide set I'm sharing is very much condensed to some of the trainings that I do out in our communities. And so what I want you to be able to take home is being able to self-reflect on your own knowledge, understanding, your attitudes, behaviors in working with or serving our tribal communities, our people, and our patients. My hope is to guide you through a recognition that we never fully arrive in our understanding. I am constantly learning as I navigate through different situations. It's definitely a lifelong process. It is absolutely a process of humility. We demonstrate it in our ability to respond to the needs of our communities we serve and measure our successes in greater understanding of the inherent strengths held within each of our communities. In these slides, what you see is a picture of our bunch stars on the right. And many of you may know these as the Pleiades or Pleiades. However, in the Lakota and the Blackfoot community, we know these as our lost boys or seven little girls. Right now, we have snow on the ground, and this is the time of year when they appear in the sky. And so I put this up here to try to help you understand a little bit more in depth about how we move through this world, how our connections are greater than the physical reality. We have a connection to our spiritual side, a connection to the cosmic space around us, and all of that is also deeply interconnected with our land base. These stars are a reminder for me that we have so many ways of looking at the world. And when I think about the story of the seven little girls and the lost boys, this helps me to recognize and understand how important community, how important kinship and taking care of one another. Those are what the story morals tell us, the ethics and the morals to remind us we are beyond ourselves and not looking self-centered, but looking outward and looking at how can we take care of one another. So when I think about right now, December 3rd, if you were to go outside and you would see that clear night, we have our moon, Kokomixum, in our Blackfoot language, who will be coming across and meeting directly with our lost boys and our seven little girls. The snow on the ground is when we tell our stories. And so as I move through the next several slides, you'll hear a little bit about my own family's journey, and I want you to be mindful and sensitive that I make myself vulnerable as I share some of these things with you. However, I think it's so critically important in understanding that different lens, that view, and that historical perspective that brings us to where we're at today. Next slide, please. So here you see falling stars recorded between 1883 and 1884 on our winter counts. This is a Lakota winter count. And many times in our Lakota and Blackfoot people, we have demonstrated what we know and the way we know and how it exceeds the understanding of Western academic epistemologies and pedagogies. And I'm going to have you should be able to back up one more slide. There you go. So when you look at these stars, being able to recognize that uh, we have always been collecting data, we make observations, we document history, we are rooted in science, in systematic process, bodies of knowledge, and ways of understanding. Next slide. Growing up, I learned our painted nitoyis, or our lodge, our home, our teepee, map the ways of knowing of our people. It's a star map, a story map, a reminder of our ethical principles, our values, our morals, our connectedness. So Lakota and Blackfoot ethics are rooted in holistic worldview. We look at things from the spiritual aspect, the emotional aspect, the mental aspect, the physical aspect, and they are all interconnected, intertwined. That prioritizes community consent, collective knowledge beyond ourselves, ethical research, ethical healthcare practice includes respect, balance, relational accountability. It takes into account our connection to our land base, our ancestors, and the stars and cosmos around us to help us really understand that deep interconnected relationship that makes us who we are. The same as Nitois or our TP teachings remind us. Ethical research with Indigenous communities requires researchers to prioritize the well-being and autonomy of the community. The same way as our healthcare providers, as they're navigating through our communities, should also be thinking about. This is a fundamental shift from traditional research models or healthcare systems, where we can sometimes see extractive practices reaching beyond collaborative partnerships. We want to be mindful of prioritizing Indigenous self-determination and culturally appropriate methods, ensuring our communities have meaningful involvement and control over processes and outcomes. I will often ask some questions, and these are, of course, rhetorical questions, questions to ask ourselves. Is this Indigenous driven? Is it Indigenous guided? Is it for my own purposes, someone else's purposes, or is it for the tribal community and the individual I'm working for and working with? Am I asking to help? Am I asking permission? All of these questions are important for us to be mindful of, to ask us, to ensure that we are truly moving forward with an intention of allowing our tribal communities to lead. And part of that is understanding a little bit more about the terminology that is out there and recognizing that this terminology is tied to some very important concepts. And so go ahead and move the slide forward. Here we have a breakdown of three different terminology words that we'll hear and we'll see as we move through literature, as we move through rules and regulations, and as we listen within our work that we do. The first one is American Indian and Alaska Native. And so there's still a lot of education to be done to understand and recognize that American Indian and Alaska Native is a specific definition that has a well-defined legal context within the United States. It is a definition that establishes our government-to-government relationship with the United States. It is specific to the tribes and tribal entities that have engaged in treaties and are federally recognized within the United States. There are definitely ethnically and culturally and linguistic differences. However, what oftentimes is not understood is that American Indian and Alaska Native is a specific political entity. We are not a race. This is a political entity that we sometimes forget. As we move into the next term, Native American is a term that gained momentum in the 1970s and was often synonymous with American Indian. However, remember, American Indian is tied to legislation, to treaty, to that political classification, whereas Native American is a more broad term that you may hear. And as we look at how that is defined, it has a broader definition that is more inclusive and can include members of any Indigenous people within our Western Hemisphere. So that would include, for instance, South America, the islands, Canada. And so when we're looking at terminology, being able to recognize and understand, we may hear all of these different terms. However, understanding, okay, we do need to be mindful that if we hear American Indian, Alaska Native, that is a word that was defined by the United States, not by our Native people. It was specific to those relationships that are legally binding with those tribes. Native American is a terminology that will be used broadly and can be more inclusive. And then we get into the term Indigenous, and this is a word that I use a lot. I hear a lot because it is the most inclusive. This is where we look at communities who had pre-existing sovereignty prior to contact with settler populations, and we have Indigenous people around the world. However, it's also important to understand that, for instance, myself, when I'm thinking about what am I called, I am Lakota, I am Sichango, I am Nitsitapi, I am Apatosipikani. Those are the names from our specific places. Those are the names from our specific people. And being able to recognize and understand that each individual will have a way they want to be identified. Next slide, please. So my own story begins in Rosebud, South Dakota, which is where I was born, within Indian Health Service. And this slide is a slide set that pulls from this historical documents within my own family. You can see in the upper left hand, you have this roster with an accounting of signatures for and what I'll share, this is 314 adult male Indians over 18 years of age belonging to the Lower Brule Agency in 1889. On there is my own great great grandfather's mark, his name Mato Paji Chikala. That history is so critically important in understanding how we've navigated from being fully independent, having full sovereignty, to moving through policy after policy from full sovereignty, surviving conquest, navigating treaty making. And the reality is that our communities were forced into a dependence. And when I think about cancer and the cancer continuum and the things that we struggle with now, a lot of what I have focused on in my background is basic things like food security, food insecurity, food access, environmental impact, environmental built structures. Where does that come from? How do we arrive at where we're at today? And how do we help our communities be able to acknowledge, understand? Because there is a grieving process that we move through in that. When I think about my mother being on the Blackfeet Reservation and having to navigate the IHS healthcare system, no one gives you an instruction book. It is where we are at today. How do we move through purchase and referred care and getting authorizations for travel or transport? And then moving into a bigger city and navigating the healthcare systems there for cancer providers, cancer specialty. How do our families help do that when we've come from a very different system than the rest of the United States? So being able to recognize that for a long time, our family members have been raised by family members who have had to navigate this, asking for permission, being left with very little and working with very little as they navigate systems. Next slide, please. This next slide is really being able to also understand that even within just the last 100 years, and I'll share with you the pictures of my own family. These are individuals who were born in 1900, who were alive when my children were small, who shared firsthand stories and accounts of how things changed from decade to decade. They were part of those policy changes. From migration, hunting, gathering, cultivating, to sedentary confinement, surviving on rations of tea, coffee, salt, bleached flour, refined sugar, lard. Even myself, thinking about in my lifetime being born into the food distribution program on Indian reservations, being born into the special nutrition support program for women, infant, children, WIC in 1972. What I think about here is we think about what we ask our patients and how we emphasize nutrition and physical activity right now, right? So right now, when we look at treatment guidelines, our focus is on lifestyle change when we're looking at prevention strategies. even when we're thinking about cancer and thinking about nutrition and cancer prevention, we will emphasize nutrition and physical activity. We'll emphasize breastfeeding. However, what is that historical journey that really is not historical? This is within many of our lifetimes. What is that first line within our treatment algorithm? If we're continuing to focus on nutrition and continuing to focus on physical activity, do we understand the context and the lived experience of our communities that we're working with? Have you ever asked yourselves, does their lived experience come from generations of adapting to the food source that was available to them? Systems and strategies by the United States government where they were restricted access to food. They were provided high simple carbohydrates, high fats, high sodium, high processed food. Corn syrup. I was one of those babies where corn syrup was added to my bottle, following those instructions that are right on the corn syrup label provided through the uh, commodity program. So, being able to understand and recognize that as we ask our patients, uh, are we truly understanding where they have come from? When we think about even our palates these days, when I work with our infants and our children, understanding that our people have changed in the way our palates have adapted to these foods. So when I introduce maybe more nutrient dense foods, whole foods, that's very different than the access that has been available for generations. An infant's taste buds and palate begins in utero, yet mother is surviving on commodities. And we're talking about breastfeeding when we've had generations before us who had formula, infant formula, emphasized as important in priority over breastfeeding. So, all of these messages that our families have received culminate in where we are at today. And now we're seeing that reverse and change, but are we understanding what that lived experience has been? Next slide, please. In
Dr.
addition, we
Smith?
have, yes,
Oh, sorry. I'm just letting you know we have about a minute left before we need to move to the next speaker.
sounds good.
Thank you.
So, in addition, we also think about the generations of families that have moved through the boarding school era. And so being able to understand that there hasn't been a lot of time for families to be able to really, I will say, heal from a lot of the policies. So as we move through to the next slide, that next slide just emphasizes that we have these systemic federal policies without recovery within our communities. Next slide, please. We have this timeline of healthcare where we've moved from that full tribal sovereignty to self-determination. Next slide, please. And so recognizing historical trauma, as Dr. Maria Yellowhorse Braveheart shared, the cumulative emotional and psychological wounding over one's lifetime, and from generation to generation following loss of lives, land, and vital aspects of culture. Next slide, please. We think about Abigail Echo Hawk and her summation. We are not a historically underserved population. My history is one of ancestors who survived so I could thrive. My history didn't start with Western civilization. I am colonial underserved. I am institutionally underserved, and I am historically resilient. Next slide, please. So, our work has really tried to shift our conversations from disparity to resiliency. Next slide, please. Owning our power in our Indigenous values. Next slide, please. To create a new kind of interaction, creating a healing forest. Next slide, please. And we have this continuum of having a sense of cultural awareness, growing in cultural sensitivity, moving towards cultural competency, beyond cultural competency to cultural humility, so that we can create a forest of cultural safety. Next slide, please. Here you have definitions between cultural competency and cultural safety. And I'm going to focus on the next slide, please. What is cultural safety? Because this is really where we are working hard to make a difference. Indigenous cultural safety is the process of making spaces, services, and organizations safer and more equitable for Indigenous people by considering current and historical colonial impact and seeking to eliminate structural racism and discrimination. Next slide, please. Within the Montana American Indian Women's Health Coalition, of where I currently serve as president, we are guided by our true north to protect, to preserve, and to promote our sacred ways. Next slide, please. Identifying our strengths through empowerment. Relationship is so critically important. Respect and reciprocity. Next slide, please. So that we can start creating a space for a new story, re-engaging our communities, connecting, and rebuilding trust. And once again, just due to time, this is very condensed. I'm always happy to answer questions, but I'll go ahead and end there. Thank you so much.
Thank you, Dr. Smith. As we go to our next presenters, we have Hillary and Jeremy from the Utah Department of Health and Human Services.
Hi, everyone. Yeah, if you want to show our presentation, we're fine with that. So I'm Hillary Macris, and I'm here with Jeremy Taylor, and we work for the Utah Department of Health and Human Services. And so we thought it would be best to help kind of describe some of the work or how we do our work here within our agency. If you'll go to the next slide. So, and just like Dr. Smith had made reference to, we're talking about American Indian, Alaska Native, we're talking about political status. So in that, like she shared, it can be a racial category, but how we do our work, we do it within the scope of the political status. If you'll go to the next slide. So most people are not aware, but we have 8 tribes that are affiliated with the state of Utah. So if you go to the next slide. So here are some of the tribes that are located here. And as you might see, if you'll go to the next slide, some of our tribes actually have, may have some land here in Utah, but they also have land in other states. So this is a representation of the 8 tribes on the map of Utah. You can see that they're spread throughout the whole state. If you'll go to the next slide. And so we thought we would best describe like how we do our office, how our office does our work. So I don't know if I mentioned that we're in the Office of American Indian Alaska Native Health and Family Services, but internally we've shortened it to Indian Health Family Services. So that's IHFS, if you might see that. If you'll go to the next slide. And this is our office. So in Utah Department of Health, we have 6 of us together. So most of us are based up here in Salt Lake. So we work at the Mesa building, which is across the street from the State Tax Commission building. But Jamie Harvey is our equipment administrator, and he is based out of Blanding, Utah. So as you can see, there's Ozzy, Jamie Harvey, Jeremy Taylor, Alex Merrill is our epidemiologist. I'm the tribal health program manager. And then we have Cassie John. We have 2 grants, an opioid and a tobacco grant that we work on. If you'll go to the next slide. So this is actually Jeremy. So I'll lead it, have Jeremy take over.
Hi, everyone. I'm Jeremy. I'm the tribal health liaison for the agency. Like Heather had alluded to, we primarily work in that political relation, that government to government relation between um, us as an executive state agency and tribes on that level. So, and through that, we have a consultation policy that is signed by the 8 tribes that are affiliated with Utah. So we have signatures from all the tribes and also the Urban Indian Organization, Urban Indian Center of Salt Lake that exists in the state. So our policy is a policy of consultation and conferment. We're in the process of this year renewing that policy again. So we have a 5-year agreement with the tribes and the Urban Center, and how we engage them, like I said, on that government to government relationship based in that trust responsibility between governments. If you'll go to the next slide. This is kind of where we're located. We're located pretty close to the executive director or EDO because in the state, tribes have emphasized the importance of having that established executive relation and executive decision making because many tribes, like I said, they are sovereign and independent, and they have that. They want that level of decision maker in the room when they talk to them. So when we engage with us, we try to have those high level decision makers in there that can make decisions direct with tribes and have that conversation and exchange of ideas in consultation. If you go to the next slide. And so one of the ways we also operationalize that is the Utah Indian Health Advisory Board. This is a board created in statute in collaboration with the tribes to essentially guide and recommend our agency on public health matters. With our agency merged, so now we include human services in some of that aspect. So we're still working out what that looks like. We used to be 2 agencies, the Department of Health and the Department of Human Services, but once we merged, over the coming years, we've been working to emphasize how we incorporate that new element of human services in, but still carrying that thing of having tribal representatives. So they're selected by their representative bodies or councils, and they sit on the board and kind of direct our agency in terms of policies that come out, essentially it's anything that's related to public health matters that would affect the tribes in any way. So many of our Medicaid waivers go through this policy. Many of our statewide plans go through this agency board as well. And so it's a very effective way to operationalize and connect with tribes. But this doesn't supersede directly meeting with tribes and directly consulting with tribes at their request, or if we require the consultation. Next slide, please. And this kind of Utah, this is kind of how the system is. Many of you are aware of the Indian Health System or the ITU, this Indian Health Service. Utah only has one IHS facility, direct service facility, up in the Uinta reservation up there. We do have some connection with the one in Toyac, Colorado. So those are the 2 direct service tribes that exist in the state. And then we have many 638s between a few tribes that have essentially through the Indian Self-Determination Act assumed the responsibility of providing healthcare and public health authority to their nations. So we have 5 of them in the state, and then we also have the Urban Indian Center, which is a great partner for the Urban Center. They cover in Utah, it's 5 counties located around Salt Lake City. It's called the Wasatch Front, so that's kind of where their service area is, and they deliver services to that area. Next slide, please. And this is kind of a geographical representation. As you can see, it's kind of spread out throughout the state. So we have one of the largest tribes in the nation, but we also have very small tribes. So our agency works across all sizes and all capacities. So we have to be very flexible in terms of how we create any policies, any plans, and work with all the tribes to make sure it fits everyone. It's not just a one-size-fits-all approach. Next slide, please. And so here's another representation of that. This is just kind of for those. So there's more context of how they fit the tribes and the ITU system. I think the next one's you, Hillary.
Yeah, so we just kind of wanted to highlight some tips, like when you're working with tribes or tribal communities, and kind of some best practice with working with them. If you'll go to the next slide. And Jeremy, I think you're supposed to do this one.
Yeah, I do this. Yeah, so the biggest thing I think in working with tribes, especially on that government level, is understanding what tribal official you're working with and what capacity they have. It's always important to make that established connection and understand who you're talking to. Make sure you're not just talking to, make sure you're talking to someone with decision-making ability. Just like if you're talking with any governmental agency, you want to make sure you're talking with the right person. So it's always good to either reach out to the council or reach out to some of their executive. Some have tribal administrators, some executive level, to say, is this the right person I'm talking to? Always establish that early on, like you're working with any other government agency. Treat them with that mutual respect you give to all governments. If you go to the next one. And with that, address tribal officials, tribal leaders by their proper titles and terms, whether that's chairperson, president, council member. Just that's a good way to build that trust and relationship, mutual respect. Again, just like you would any other official that you're speaking with, it's important to establish those kind of norms and respect as a government to government. Next. And then be mindful, tribal partners are very busy. They are wearing multiple hats. A lot of them lack capacity, so they're multiple hats, multiple agencies. Some departments may be all run by one person. So it's important to understand their time and be timely with your interactions with them, and come with a clear purpose and ask whenever you do approach tribes and want to engage them in consultation. I think this one's you, Heather.
I keep losing my mouse. So, when you're working with tribal partners, you want to be transparent. So I think just being clear as to what you have going on or what you're planning on doing or what the plan is. And then also just follow through. It's so critical in building that trust with the partners. So if you said you're going to do something, then do it. Don't overpromise. If there's something that you need to find out more information about, it's okay to say, let me get back to you on that, and make sure you follow up with that. Get back to you. If you'll go to the next one. So keep them informed on the process or where you're at in the process. So sometimes things might get held up, or like you had a great presentation, things were going well, and just kind of keeping people informed as to what's going on. And be conscious and flexible of time and time allotted. Sometimes you're given an amount of time to present, and sometimes they will say, oh, we'll give you 20 minutes, but really you might get 10. And so I think just being flexible with that, or sometimes they tell you get 20 minutes and you may have been asking or answering a lot of questions that they may have. So it may become, a 40-minute presentation. So you have to be flexible and kind of roll with the punches and, go with how things are going. And I think the next slide. Oh, and it's also good to express gratitude where appropriate. So just, thanking them for their time. A lot of the council meetings, if you are presenting at a council meeting, there are formalities that are there. So, it's just like talking to the legislature. You want to make sure that you're able to answer questions and like, chairperson, am I able to answer this question? Or if there are follow-up questions, but also just thanking them for their time, and you appreciate them listening to you. If you'll go to the next one.
And 1 more minute.
Okay. If you'll go to the next slide. Yeah, so this is just our office and this is our website. So if you have any questions or need to get a hold of us, all of our contact information will be there on the website, but also we're sending the slides out, so you will have it there. We can answer any questions if you guys have any. But yeah, like our office does things a little bit differently because we are focused on health. So again, we work with the tribal partners, or the tribes themselves, or the tribal partners, which can be the 638 clinics or the Urban Indian Center of Salt Lake. So, and I don't know, are there any questions? Jeremy, did we get everything? Sorry, we kind of went fast.
Yeah, I think we covered it, unless there's any other questions.
Awesome. Thanks, Hillary. Thanks, Jeremy. I just want to say, appreciate Dr. Smith setting the stage, speaking to the resiliency of our Native communities here in the United States, and talking about the historical practices of what we've gone through and are continuing to go through, in surviving a lot of what we've endured, and talking about ways to move forward. And then Hillary and thank you for touching base on the practical day-to-day approaches to working with communities. A lot of it, I think, is really important to understand where the communities and the tribes are coming from, but ultimately to honor their sovereignty and to meet them where they're at and on their terms. And as we move forward into the next section of the webinar, we're going to be highlighting some of our community spotlights here in the area that we serve, specifically some of the community organizations and research going on in the communities. First off with Dr. Woodall from the University of Montana.
Thank you, Nathan. And thank you, Jareth and Hillary and Jeremy, for setting the stage so nicely for these spotlights. This is a picture of the University of Montana campus where I am, and I'm going to be talking about our research partnership with the Confederated Salish and Kootenai tribes in Montana. And we have been working together for the past, thank you. We've been working with on projects around pharmacogenomics and precision medicine and how we can use genomics to better tailor medicines towards people. And so a lot of this research has been on the research side and then ultimately helping to move through having these genomic tools available for clinical utility. Next slide, please. I just want to talk for a minute about genomics and that we have more work to do to be inclusive of global variation. So this is a picture that looks at the number of people participating in genetic studies across the board, not just pharmacogenomics, but and you can see by year and then by population. And certainly there's a huge explosion in the number of people participating in genetic studies, but it is really imbalanced towards people of European ancestry, which is there in red. You can see that the largest proportion of people participating in genome-wide association studies are people of ancestry. And on the right-hand bar, you can see that that's really discordant with the proportion of the global population that are made up of European individuals. And there's a lot of data on this slide, but one thing I want to point out is what's not on this slide is that Indigenous people are not represented here. And they make up only 0.02% or probably less than of participants in genetic studies. So very little is known about genetic variation with regard to pharmacogenomics or other genetic medicine. And the reason why this is important is that we're getting to a space where genomics is starting to be used more clinically. So we need to make sure that we have data from Indigenous participants so that these clinical tools will be useful for them. Next slide, please. And I also just want to say something about the rurality that Nathan talked a lot about, was that genomics is also not something that is widely available in rural and tribal communities. We would have to go to somewhere like Salt Lake from Montana to get that. So again, thinking about what are some strategies to make sure that when these medicines are more widespread, that they aren't only available in certain places in the country. Next slide, please. And another map is looking at the percentage of people from the last census identifying as American Indian, Alaskan Native. And next slide. Just showing you Montana here. You can see that Montana has a very large proportion of American Indian people. And then next slide, please. So I want to talk to you about the research that we've been doing with the Confederated Salish and Kootenai tribes. And this is a map zooming in on Montana and looking at the tribal territories in Montana. There are 12 federally recognized tribes in Montana, and they reside on 7 reservations, with the reservations in this kind of brick orange color. So the Confederated Salish and Kootenai tribes reside on the Flathead Reservation, which is in the northwest corner of the state. And the Confederated Salish and Kootenai tribes are made up of 3 tribes: the Salish and Pend Oreille, whose traditional lands are there in blue, and the Kootenai, whose lands are north, next to just south of Canada. And Missoula is just a touch south of the Flathead Reservation. So Missoula is on the traditional lands of the Salish and Kalispel people. And we've been partnering with the Confederated Salish and Kootenai tribes for the past 18 years, more than 18 years, on a variety of pharmacogenomics projects. But I want to talk just a little bit about some of the challenges in conducting research that have already been discussed previously with speakers today. But genomics research is even more fraught. There's certainly examples in which researchers have done really poor research and had bad practices working with tribal communities. There's a perception that research has provided little benefit and even some harms. So what is the benefit to communities to participating What is the benefit for their families? And then obviously a large legacy of mistrust, and as I mentioned, particularly in genomics. But how do we move forward to find common ground? Pharmacogenomics is something that is being used clinically, and not super widespread, but it is becoming more common. But as I mentioned, we need more data to make sure that this kind of pharmacogenetic testing will be useful and valuable for Indigenous populations. So how do we move forward with research that is acceptable and is aligned with the healthcare priorities of the CSKT? And we have based our research on the principles of community-based participatory research to find that common ground. Next slide, please. And the principles of CBPR, community-based participatory research, are showed here at the bottom with the triangle that represent equal buy-in and stakeholders with the community members, with the University of Montana, and with the healthcare providers that serve the CSKT people. On the left, again, that's a picture of University of Montana. In the middle is the picture outside of the Tribal Council Complex in Pablo, Montana. And on the right-hand side is one of the tribal health clinics. This one is in St. Ignatius, Montana. So the community engaged work that we do really really values communities in all aspects of the work, helps to ensure that the research that we're doing is aligned with the community priorities. And then also it's an opportunity for bidirectional learning and building trust for research going forward. Next slide, please. One of the first things that we did was to form a community advisory board. That was in 2010. And here's just a couple pictures of some of the work we've done with our community advisors over the years. On the left, we have held a number of genetic education workshops where we talk about what is a gene, what is a genetic variant, how can we use this information to improve medication therapy. And it was a hands-on active learning kind of environment. You can see in our hands, we're making a cell with craft supplies, and it was a fun environment. On the right-hand side, I've invited our members of our community advisory board to my lab at the University of Montana so that they can see where the biological samples are processed and where they're stored, et cetera. Next slide, please. We also had a grant that ended a couple years ago around what are some of the ethical challenges about conducting research with American Indian and Alaska Native people. And it was centered on three main things. The first being, what are tribal health priorities for research in precision medicine and pharmacogenomics? What might be not priorities and no-goes? Also, what do we need to be thinking about with return of research results to participants and to the community? And then finally, thinking about data stewardship, owning of the data and sharing of the data. Next slide, please. I just wanted to give you a snapshot of some of the work we've done with the CSKT over the past 18 years. I'm going to talk super briefly about the tamoxifen piece. When we started this project in 2007, cancer was really the focus of the community. There was an oncologist who came from Missoula to the reservation who was treating patients and observed what he thought were differential responses to tamoxifen and other chemotherapy agents. So this was one of the first projects we embarked on, was to look at response to tamoxifen, which is a drug used in estrogen-positive breast cancer, to see if we could see genetic differences amongst participants. But you can see that we've conducted a variety of other studies over the years. Next slide, please. And that research recruitment looks a lot different than it does in maybe larger academic medical centers, where we go out to the community to talk about the project, to consent for the project, and then to disseminate and report back on the project. On the left here, this is my car loaded up with our supplies for drawing blood, for freezers that can be plugged into a car or a wall, etc. On the top right, this is us recruiting at the Arlie Powwow celebration that happens over 4th of July every year. And then a couple of examples of us recruiting at health fairs. So thinking a little bit uniquely about maybe we can't rely on sort of traditional ways to recruit participants into clinical trials and clinical research. Next slide, please. And I just want to talk for a minute about dissemination. So this work that we've done has been published in academic journals, which is, of course, sort of a requirement for academic life, but we didn't want to just leave it there. We try with our research projects to disseminate the results back to the community. On the top left, This is an example of an article we wrote that was published in the Charcusta News, which is the tribal newspaper of the Flathead Reservation. This was talking about the results of that tamoxifen study, and it talked about the timeline of the partnership. This was something we wrote with one of our community advisory board members who he's now retired, but he was a reporter at the Charcusta News, so he helped us write it in lay language and targeted to the community. And then on the bottom right, we also made a video sharing the results of that tamoxifen study. If you want to grab that QR code, that'll take you to it. We worked with our community advisory board to gather photos from the community. This is a picture here of the south part of Flathead Lake on the Flathead Reservation. We have pictures of family members from our community advisory board so that the video again reflected the people who participated in the research. And next slide, please. Thank you. Just to summarize, community-based engagement or community-based participatory research and community engagement has been really essential for this work, working with the Confederated Salish and Kootenai tribes, but also really important to be thinking about other Indigenous communities and underserved populations. And then here, just some of the values and practices that strengthen opportunities and partnerships, but I'll skip through those because I know we're short on time. And then next slide. Just to thank a lot of people here at U of M, but also importantly, my partners of the Confederated Salish and Kootenai tribes. And my last slide is just one last picture from the Flathead. So, thank you.
Great. Thanks, Dr. Woodall. Now we'll turn this time over to Dr. Adams from the Montana State University's CARE program.
Thank you so much for having me today. I'm really happy to be here, and it's great to hear everybody else's presentations because there's a lot of ground we've already covered. So I'm the director of CARE and a professor at MSU. And next slide, please. CARE's mission is to really help reduce significant health disparities in Montana's rural and tribal communities by partnering with them. And we do use community-based participatory research as our primary means of doing that kind of work. We are an NIH-funded center, and we do work anywhere from cancer prevention all the way across the spectrum of different kinds of health needs, depending on the communities that we work with. Can you go to the next slide, please? So I wanted to just give an example of some of the other investigators at MSU that are working with tribes. This is by no means an exclusive list. This is just kind of our top funded investigators doing everything from work on sleep and belonging on the Blackfeet community to water quality on the Crow to sexually transmitted diseases and other issues with alcohol and drug recidivism at Fort Peck. And then Emily, I'll be talking about her work as well as mine a little bit later in the presentation. So we do a lot of mentoring of junior faculty and help them learn how to do CBPR. Many of them have worked with tribes, but a lot of them are brand new to working with tribes, and we build them up so they're able to get to long-term lasting relationships that are really respectful and work well with our tribal communities in Montana and beyond. Next slide, please. I want to put a plug in for any junior faculty that are maybe watching this. We are having our next Promoting Indigenous Research Leadership Conference in March in Tempe in conjunction with Arizona State University and Johns Hopkins and others. We've held this for the past 5 years. These are some of our graduates. And this is for Indigenous researchers and ally researchers that want to learn more about how to get funded and how to manage that kind of research. So shout out to us if you're interested in that. We'll be sending out information on that soon. Next slide, please. So I want to step and take a deep dive into one program that we're currently doing with Huntsman Cancer Center. We currently have a center within our center called Hope and Care Together. So it's with the Center for Hope at Huntsman. And this is one of the programs that is funded through that center. And it's called Turtle Island Tales, and it's based on a number of R01 level trials with multiple American Indian communities across the country. And this is a dissemination and implementation project working closely with multiple communities about how they want to get this work into their community. Next slide, please. So we have 9 tribal sites that are currently in the program, and many of them have come to us and asked to be part of this. Some of them we started with as part of this grant. We're using the REAIM framework with REACH as our primary outcome. And we do have a community implementation team in each community and an overall advisory board that represents all of the sites that comes together quarterly. Each of the sites is doing culturally specific adaptations and looking at how they want to roll it out. And one of the most exciting things that's happened in the past 2 years is that this was a home-based program that I'll talk about that has now been integrated into classrooms per community request. And of course, there are interesting challenges by all kinds of stuff going on, including the dissolution of SNAP Ed this year. Next slide, please. So I want to just talk a little bit about the program. So again, this is Center for Hope, and our primary collaborators on this project there are Paul Esterbrooks, Dr. Esterbrooks and Dr. Merle, and then Emily Salloway and Darnell Rise at the Door have been our primary advisors for the entire project for the past, I'd say, probably 9 years. And we obviously have lots of other advisors from other communities. And then this is the research team. Dr. Chumeko is the PI on the project. I brought this work with me from the University of Wisconsin-Mercy, and I'd worked together for many years. And Teresa is our program manager and our research coordinator, and Eliza's biostats. Next slide, please. So these are our community partners, multiple community partners. We are a SNAP Ed approved program to work in home-based wellness promotion, and this is a cancer and chronic disease prevention program. So you can see all the different communities that are, and I want to give shout out and thanks to all of them for participating and continuing to teach us what we need to know about how to help this be a better program for all of them. Next slide, please. So we've already talked a little bit about this, but I did want to touch just quickly on some of the strengths that we build on in terms of food systems, intergenerational knowledge, and holistic wellness. Next slide, please. So we want to improve not just the physical health of families, but mental, emotional, and spiritual well-being. And that was the edict that was passed down to this entire team from all of the communities that we've worked with. Next slide, please. So again, this has been going on for a long time, and we're in the midst of dissemination. Next slide, please. I think it's got an extra piece to that. Yeah, so that's the home-based program. Next slide. Oh, it's going to do this clicking thing. And now we're moving into this reach way of doing things. Next slide, please. So the program structure is printed lessons, a children's book, primarily from Native authors and illustrators, support items and recipes and handouts. These are the titles and the topics of each lesson. We have 12 lessons, which we are modifying for classroom delivery compared to the home delivery that this shows here. Next slide. This is just the holistic approach that I talked about. We do have it based on a story character called Igmu, who's Bobcat, and his grandmother. And then our age group is 3 to 8, a primary age for a developing taste and other healthy behaviors. Next slide, please. Just a picture of one of the monthly lessons. This is the beginning the journey lesson starting the first month. And you can see stickers and things for the kids and then information for parents. So it does a lot of, one of the things it does is have parents and kids work together, and that is really important. Next slide, please. So we also have films. We've just completed the last 3 films. You can see these on our website. The first 4 films of the 7 grandfather teachings are on that site. Next slide, please. So just an example of this is the tribe in Warm Springs that has done a lot of work. They have three different languages on their reservation, and they have done a lot of work, next slide, in incorporating language into the lessons. So the packets are sent open into the communities, and then the communities put in additional information on what they want to put in, whether it's recipes or language, etc. And that's been a really important component for each community to be able to tailor it to their own needs. Next slide, please. So again, here we are where we're initially home only. Then we did it through the classroom with Head Start delivery and in-classroom backpack stuffing. And now we're into home plus classroom. We've then also had a number of sites doing classroom only. Next slide. So this is our reach right now. We're very excited that we've reached over 1,000 children through our classroom and home-based work over the past 3 years of this grant, and continue to work with different communities in terms of improving this. Of course, with the decimation of SNAP Ed education, that has been hard, and we're working through how to get the delivery and teach teachers how to deliver this themselves. Next slide, please. So again, everybody's talked about this, but respectful community engagement is so important. We're trying to focus on how we're sustainable. How do we help communities continue this program when grant funding ends, and working through those challenges already with SNAP Ed funding being eliminated. These are some pictures from some of the kids in the classrooms doing some activities, and some of our wonderful SNAP Ed educators who have been so helpful to us in teaching us what we need to do. Next slide. I think thank you very much, and hopefully that's enough time for the next person, and you can reach us at all those different sites. Thank you.
Thank you, Dr. Adams, for talking about the amazing work done at MSU and the CARE program, and touching on the H2 program with Center of Hope. We really appreciate it. And then we'll move over to Alma McCormick with Messengers from Health and the Montana American Women's Coalition. Alma?
Todadie, chik diwagum, nawabe chik, birugawalaja, binaje wach basuk, basakale, binaje chish kowilash kolekuk. It chicken nawabe vilalak, bililakos, this is a homework. I just greeted you in my first language, my Crow Indian, Apsaloga language, that today is a good day. It's good to see each one of you. Every day is a good day. The only time you can say you have a bad day is when you lose a loved one. That's how important life, having one another, our family, our loved ones, it's very important to us. And so that's why we do what we do to help our people. My Crow Indian name is Sacred Shield. I'm named after my great-great-grandmother, Pretty Shield, who was well known amongst the Crow women, a woman of faith, a woman who utilized natural medicinal plants and prayer for healing. I'm blessed to be here and to share with you about Messengers for Health. I'm the executive director of Messengers for Health. Before I even speak about anything, I will have to share with you why I am passionate about what I do. I lost a little twin daughter to cancer. I had a boy and a girl, my first babies. My little daughter was diagnosed in the 4th stage the week of their birthday when they turned a year old with neuroblastoma cancer. We tried all the chemotherapy. She seemed to be doing well, but she did pass on. Through that experience, it filled my heart with compassion, my faith, a stronger faith in Akbaratia, the Creator, God, Lord. And that is why I do what I do. I've been placed on a divine path to help my people. Back in even the early 90s, probably even before then, Crow women were not going in for cancer screening. Neither were any men folks. In the Crow language, there's not even a word for Crow. For cancer. We describe it as Balenem Chavish, that dreadful and awful disease. When you hear that phrase spoken in conversation and you overhear that they are describing someone, Balenem Chavish Kodesh, then we know that person has cancer and they will not survive. The words we speak are sacred and powerful. So we're careful in the words that we speak. We speak words of faith. We speak good things. When we speak words that are negative, then we can bring that upon ourselves. So because of that, we didn't want to speak this word. It was kind of kept quiet. When people had cancer, they were like withdrawn. We didn't even know. They didn't want to talk about it. It was almost like it was embarrassing. There was no hope. that this person was going to die. That was the result. But things needed to change, and things had to change. After I went through this trial of the devastation of losing a little child to cancer, I have been placed on this divine path. I can't explain it any other way. Doors begin to open up. I began working with the state of Montana, which is known as the Montana Cancer Control Program. And it began my path. I traveled statewide for a couple of years, going to all the reservation sites, recruiting and enrolling women, educating women about the importance of going in and having cancer screening. But my heart was to develop something with my own people. And that's how Messengers for Health came about in 2001. I've been blessed to meet my research partner. I met her way back in 1996. We began work in 2001. She's a professor from Montana State University, Bozeman, Suzanne Held. We have been working together since. We realized that it's going to take a Crow woman, someone from the community, someone that other people knew and trusted, to be the one to go out and talk with other women, someone who truly loves and cares for them. That's how the messenger, the approach, this lay health advisor approach, I guess you might call it, very effective. Community-based participatory research. I am so thankful for Dr. Cherith Smith and everyone else that presented. It was a wonderful layout of how the reason why Messengers for Health has been effective and has been able to reach our people in the community. The importance of building that trust, because there's much mistrust. As soon as you hear the word research, our Indigenous people shy away from it, and it has to be understood because of much mistrust that has taken place. But when it's done respectfully, when you allow the community to take the lead, I'm kind of like the liaison of my community. And my people know what I've been through. They knew I lost a little daughter to cancer. They knew how I coped. It could have really taken me down the deep end, which we've seen happen too many times and so prevalent amongst our tribal communities because of grief. Grief is the reason why so many of our people turn to substances to try to cope. So for me, it just made me a better person. It filled my heart with passion for my people. And it placed me on this path where I began helping my people, not only the Crow women, but it began to impact the men. There was a major breakthrough in cancer awareness as the messengers began going out in the community, talking with women one-on-one. Women began to go in. I seen in the presenters, one of them said, just basic knowledge. That's all our people need, is a little bit of basic knowledge. And what we shared that I felt like was a turning point, which really triggered our women, is yes, we trust in God that He protects us divinely and that He heals us. I believe that very strongly. But let's use wisdom to take care of ourselves. So that's when you go in for the cancer screening. We were funded by American Cancer Society to start this intervention. Once the funding ends, we don't want to end what we've done. We don't want to just impact and start something good and then just diminish. Our tribal communities have seen too much of that within our tribal health programs. That I'm speaking for the Crow Reservation. We want people to see that we are here. We will do what we say we're going to do. So the respect, the integrity, the sustainability, and to be here. That's why we became a nonprofit. We became a nonprofit in 2009. My research partner has continued to stay by our side. And now here we are. We completed another successful research intervention in improving self-care management, which has now been recognized as an evidence-based program. We've been helping our cancer patients with gas cards to get to treatment. We just received our first federal grant coming directly to Messengers for Health as a Native nonprofit to improve cancer care coordination amongst our people. It was mentioned that they have to go off the reservation. Yes, Billings, Montana is there. We're familiar with Billings, but once you are facing a devastating trial pertaining to your health and you are sitting there with this diagnosis, you need support. So what this HRSA grant is going to do is begin to address that initial time when our people go in and receive this diagnosis, that there is support, there is cultural sensitivity, there can be some comfort level, that this person understands their condition, they know the resources that's available from them. Eventually, we would want to see an Indigenous patient navigator placed at these clinics, such as the Billings Clinic, the St. Vincent's Hospital, Intermountain Health, where our people go for cancer treatment, and sometimes out of state. It's for those kind of things that we need to partner together. I know Cherith Smith talked about the Montana American Indian Women's Health Coalition, and that has been in existence since 2001. And Cherith is the president, and I'm the vice president. So we've come together. We're kind of regrouping after the pandemic. We need to stand strong again to partner together in improving cancer care coordination for our people. And so when research is done respectfully, mutually, with passion in your heart, you will see some good results. I am blessed to say that that has been done in the Crow Indian community. Our Crow people have experienced that we come in, bringing people from the outside, saying we're going to do this. Well, we better do it. If we come in and we do a survey with 100 Crow women 18 years and older about going in for cervical cancer screening, well, we better keep our word and know that what we are doing is going to directly benefit the women. And so that is what Messengers for Health has been able to do. We have about 6 different programs going on right now. Like I said, we've been around since 2001, and we're not ready to stop anytime soon. We're going to go forward. We need to continue to move forward to help our people. And we have to work with the tribal health, with Indian Health Service, with our local facilities. We need to partner together. And right now we started with cancer awareness, begin to address other issues. We've circled back around full circle to begin to just take a strong focus in improving cancer care coordination for our people. And I see it not only impacting the Crow people, but also other tribal people that are here locally, that do go to these clinics for care. I don't know where my time is, but I will just close there, and thank you so much for allowing me this opportunity to share with you about Messengers for Health.
Thank you, Alma. I really appreciate you sharing about the importance of culturally tailored and community-based approaches to care coordination, especially in our rural and frontier tribal communities, where the awareness historically hasn't always been there. I just want everyone to notice the poll here at the end of the webinar. If you please take that. And then also, if anyone has any questions, feel free to ask before we close out today. Okay. Awesome. I just want to say thank you again to all of our presenters and our speakers today, all the amazing work you're doing in the area that we serve and the work that you're doing with the communities. Um, Really appreciate your time today. And then for everyone who came in to the webinar and participated, thank you for joining. We really appreciate you wanting to learn more about best practices and working with American Indian communities and current projects and research and community organizations doing that work. Thank you again. Yeah.